record. There we go. All right, we are in week 4 of the CETP training. This week's training, we're going to talk about some of the underpinnings of trauma. What is trauma? What's the physiology that's involved in trauma? And hopefully, if you have questions, just chime in and ask them. I am recording this, so we can post it later. All right. So before we actually get into the physiology, let me kind of talk about what we have learned by understanding why the physiology is important has kind of led us to some what you might consider essential interventions. And the essential interventions are always about what we as the healing professional should be doing. So we can't ask the client to regulate if we aren't regulating ourselves. We can't help create an environment of real and felt safety if we haven't thought through the process from the point of view of the client. We have to understand that we're going to move through stages of helping the client regulate themselves with increasing efficiency while they're with us. And finally, when they're able to kind of heal from this, they'll be able to regulate themselves when they are not with us and they're in other settings. So that is that's our overall goal. And what we're going to look at here is what is the physiology that kind of supports the reason we're looking at it this way. So with that little bit, I'm going to just kind of ask a general question. What is trauma? Often the way I get an answer to that when I'm traveling around is people always equate trauma to an event of some kind. And there's all sorts of bad events that can happen to people, and they think of that as trauma. And what we want to do is kind of shift away from this as a definition because it's not adequate to capture what we're really working with. Trauma is a disorder of the autonomic nervous system. What does that mean, really? The autonomic nervous system regulates the body processes, not just a few of them, but all of them. And they operate automatically without any conscious effort on our part. You can't, through an act of will, change the functioning of your liver. It functions automatically. When we start thinking about anything that compromises the autonomic nervous system, that kind of a disorder begins to compromise all or part of the body processes or organs. So part of what we're looking at with trauma is that the autonomic nervous system disorders that result from trauma usually come out of the fact that the threat stress response system is being overused and overemployed. In other words, people are moving into a state of survival that is entirely appropriate for the physiology to do. It isn't that. It is the fact that once it's in that, it stays in it too long, or it's shoved into that state too often. So when we start looking at PTSD or other forms of trauma from the perspective of physiology, what we're really going to be asking is, how is the autonomic nervous system being compromised, and how is it affecting the whole being of a person? When we start talking about this system, we're really generally referring to two systems, the sympathetic system and the parasympathetic system. The sympathetic system is what we would consider an excitatory system. Let me just say that one more time. The sympathetic system is an excitatory system. Now, having the sympathetic nervous system is not bad. Almost all of the physical pleasure that we enjoy is related to an activation of the sympathetic nervous system. If you're enjoying riding a roller coaster, if you're enjoying sexual congress with a loved one, that is an activation of this excitatory system. That's not necessarily the problem, because that kind of excitation is usually relatively short-lived, and it isn't the kind of activation that will overwhelm the system generally. But when we have things that are of an excitatory nature that have a threat to them, then that system it's the same system that's being activated, but the degree that is being activated is pretty intense. So what happens when the excitatory system of this, or the sympathetic nervous system, comes on is it changes everything from the diaphragm up. In other words, it changes your breath rate, your breath volume, your blood pressure, your blood rate, your blood flow. It excites everything above the diaphragm. It also begins to inhibit everything below the diaphragm. That's just its nature. The other system that we are looking at is the parasympathetic nervous system. And the parasympathetic system is actually a health-promoting system that also allows us to have access to our executive functioning and neocortex. It is also the generator, if you will, of dopamine and other indigenous opiates that our system provides, or as my kids will sometimes say, the feel-good hormones. It has a tendency to regulate heart rate and blood pressure and body temperature. So what happens when somebody has a dysregulation or a disturbance in the autonomic nervous system is it opens the door for this internal tug of war. So let me kind of explain the internal tug of war a little bit. What we are experiencing is that there is this activation of the excitatory system, the sympathetic nervous system, and it is actively suppressing certain body systems. So we could say that it's pushing them down. And if they are pushed down in a moment of crisis or a moment of survival, that's perfectly fine and completely physiologically correct. The problem is when the excitatory system is on too long, it begins to push these things down long enough that the parasympathetic system is threatened, and it begins to push to try to activate these things. And this creates, if you will, a tug of war in the organs of our own body, where we have this system trying to activate what we need to live. At the same time, we have the system activating a suppression of those systems. We can link most of chronic health issues to this internal tug of war between the sympathetic and parasympathetic system. If you have any questions as I'm running through this, make sure that you ask. So from this perspective, what is trauma? A disorder of the autonomic nervous system that leads to sympathetic or excitatory system being dominant. In other words, the sympathetic system dominance leads to the symptoms of trauma. Now, that may be a different way of categorizing trauma from what you're used to, as that trauma is sympathetic system dominance within the physiology of the person. Questions? No? Okay, I'm going to go on. So the question really then becomes, how does the sympathetic system come to dominate the parasympathetic system? Because that's what we're struggling with, is that the sympathetic system has become the dominant system, and when it becomes the dominant system, it's suppressing a number of other systems, including access to our executive functioning system. So the sympathetic system dominance is really as the result of the whole nervous system learning through environmental experience. That may be a little bit of a different view of it for you, but essentially what's happening is there is something in the environment that is activating the physiology of the person. And it doesn't really have to be a hardcore physical threat. It can be a perceived threat or a psychological and emotional need that has been left unfulfilled for a lengthy period of time. However, the arousal effects tend to over time begin to have an effect on how we see the world, how we think about things, the emotions that we have, and the physiology that's actually expressed. And we'll talk a little bit about this as we move through this, but essentially it begins to have an adverse effect on most of the body systems, most of the emotional world, most of the psychological world, when this system is dominant too long. If you step off the curb into oncoming traffic and you're almost hit by a car and you jump out of the way, it's perfect to have that system on. But if it's on most every day, all day long, that's a problem. So when the autonomic nervous system is dysregulated, it responds with appropriate survival strategies. Now, be really careful with this one, because a lot of times we think about appropriate being socially appropriate. We're not talking about socially appropriate. We're talking about physiologically appropriate survival strategies. So if you have someone that is in a state of physiological dysregulation and they're in their sympathetic nervous system, you should see anger, aggression, hostility, impulsivity, outwardly overt manipulation, coerciveness. Those are completely congruent with survival strategies being driven by the sympathetic nervous system. What does that really mean? That most all of the behaviors that we treat in mental health really can be related to, at least in some form or portion, to a dysregulated system, and that it isn't necessarily a psychological or emotional problem as much as it is a failure for the body to regulate itself. So another important key piece of this is sympathetic dominance is not intentional or deliberate. And when you see symptoms emerge, like you see somebody that rages, or someone that's inattentive, or is having trouble sleeping, or they're highly anxious, what you're really looking at is symptoms that represent a change of some sort in the nervous system of the individual. So from the perspective that we're taking, trauma is a body thing. Now, please understand, we are not limiting, ruling out, saying that we shouldn't pay attention to the emotional and psychological impact of trauma. However, those are always housed within the physiology of the body. You might think of it like a vehicle. The physiology that we have is a vehicle that we use to get through this life. And because of the way we have traditionally thought of mental health, what we'll do is pull the tires off and work with the tires, which is the equivalent of pulling out the emotional or psychological piece, but it doesn't really have the broad impact on the whole vehicle that we would really like. Focusing on the regulation of physiology helps shift the systems that are dominant, and what we see is we can regulate the sympathetic nervous system is an amelioration of symptoms. In other words, the symptoms that normally bring people into treatment begin to go down all on their own because they're no longer in the right system to have that experience. So let me kind of give you a metaphor for this. How many of you like a nice, juicy, crisp apple? Is that a pretty common thing that people like? So if I take a bite of that apple, would it be appropriate for my whole digestion system to turn on? It would be appropriate for the saliva glands in my mouth to produce the right chemicals to break it down. It would be correct for the muscles in my jaw and throat to begin to work. It would be appropriate for the muscles along my esophagus to come online. It would be appropriate for my stomach to produce the right acids to dissolve this food and leach the nutrients out of it. And it would be, of course, appropriate for my intestinal tract to gear up to eliminate the waste products that are going to be introduced into this system. Essentially, what we have done in the tradition of mental health is we want to treat the symptoms that are appropriate with having this system turned on as if they're a problem. So if we were looking at this from an emotional or psychological point of view, what we would do is yell at the stomach for working. Or we would try to put that intestine on a behavior management plan to change how it behaves. And it is already engaging in appropriate physiological behavior. This is kind of an important concept to get a hold of. We are not talking about people engaging in, so if we say a person's depressed, we have been trained for 150 years to think of that as an emotional or psychological problem. And really what we want to shift away from on this is understanding that depression is a completely correct physiological response if the sympathetic nervous system is on. So part of the reason that we structure treatment the way we do is to regulate people enough so that they don't really need to be in that system, and give them the capacity to do that intentionally. You need any more metaphors around that you get the behavior out of the system that's on? No? Yes? More metaphors?
I have a question.
Okay.
So, how would you, so if somebody comes in with depression and they meet all the diagnostic criteria for like major depression, how do you differentiate between someone that fits the criteria versus really just having a dysregulation of one of these systems? Or is it one and the same? I'm kind of a little confused.
So essentially I would say the lion's share of all symptoms we see in the DSM are due to a dysregulated system.
Okay.
So what we're really looking at is the true occurrence of a biological or a brain-based deficit is fairly rare. What we're really looking at is this symptoms that are produced by having the physiology turned on, particularly in the excitatory system. So when we start moving into this, how the components of this system, we're going to talk about the difference between sympathetic and dorsal activation. Depression is almost always a dorsal activation, which means it's in that excitatory system, but it's the part that mitigates behavior. So the concept I want you to have at this point is simply this. Behavior is driven by the system that's on. If I'm in my parasympathetic nervous system, then I have access to my executive functioning. I can choose, I can be intentional, I can be deliberate. But when I am not in that system, then I have difficulty with those things. Good question. So let's talk about how trauma gets created a little bit more. Because of the nature of it, we're talking about, rather than an event happening, we're talking about that there's something in the environment that is intensely activating to the physiology of the person. Part of this really has to do with how the physiology works. So you all have probably heard about cortisol and the adrenals and all of the other chemicals that are dumped into the system. I call it a cocktail. So every human being on the face of the planet has a certain ability to tolerate having the sympathetic nervous system activated. As we think about resilience, what we're really talking about is that people have the ability to have that activated and sustain themselves within that range, if you will, of adaptability. So what we're kind of looking at with this highly intense thing, let's go back to our idea of the, if you will, hormonal and neurochemical cocktail. When you have this hormonal neuro cocktail, every time the excitatory system gets turned on, it dumps a little bit into your system. The problem is, in these highly intense kind of activators, something out here in the environment is happening that has caused a really big dump of this cocktail into your system. And the dump of the cocktail pushes people past their upper threshold of being able to tolerate. It's kind of, a lot of times when I'm explaining this to folks, I talk about it being, you have this ability to move up and down through here. And if you have normal stressors that activate the sympathetic nervous system, certainly you can stay within this without exceeding it. Now, you're still getting the cocktail, but it's not enough to push you over the top. The moment we have enough of that in our system to push us over the top, now we're in trouble, because the moment that happens, it shoves us into a survival strategy mode, because that is the nature of how of that excitation. So there's lots of things that can do this. Now, this is not a very popular idea in a number of ways. And let me kind of talk to you about why. Because in traditional mental health, we have believed for at least 150 years that the problem is because there's some deficit in the individual. In other words, they've got some hole in their head, they've got some hole in their heart, and our job is to patch it, fill it up, or cover it up in some way. What we're saying essentially that's different is that people are engaging in appropriate physiological responses based on what's going on out in the environment. In other words, the problem is usually not housed within the person. The problem is usually environmental, and the consequences or the reactions of the individual are what we deal with. Does that make some sense? So rather than having the idea that someone's broken or they have got some big old fat hole in their head, we assume that there is something in the environment that is keeping this alive and well. Now, once again, it's important to understand what's happening with that hormonal and neuro cocktail that's being dumped into your system. How many of you know how long it takes the body to metabolize that stuff? Anybody? So let me kind of just lay that out for you. Depending on your health, age, activity level, and your natural physiological structure, the human range is somewhere between 18 and 30 hours. In other words, you could have something awful happen to you and be in pretty good place to have a conversation about it within an hour or two. You can access your thinking and your thought process, and maybe but your body is still aroused. Does that make sense? Your body is still experiencing an arousal in the excitatory system because the cocktail hasn't been completely metabolized yet. Now, parts of it get metabolized pretty quickly, but the overall cocktail takes some time to metabolize out of your system. So what happens if you have another really intense environmental experience within, a couple of days? Then we get what one of the problems with this is that the cocktail has what we call a bioaccumulative effect. In other words, you get another dump of it before this one completely metabolizes, and now you're layering on another level. Does that make sense to everybody? Yes? No? This is one of those times where you need to nod your head so I can see if you got it before I can go on. All right. So, oops. I ended up messing my own thing up here. So what we want to look at too is is problematic for us is what we call low intensity, high frequency environmental activation. Now, remember what I said, that every time the excitatory system comes on, we get a hormonal dump. But unless it's a big dump, it doesn't exceed our upper threshold. In other words, so we aren't necessarily exceeding our ability to tolerate it. However, the problem isn't the fact that it's strong enough in and of itself. It is with low intensity, high frequency activation, we're getting an accumulated effect. In other words, if it takes 18 to 30 hours for it to get metabolized, what happens if you work in an environment or you're growing up in a family where there are 8, 10, 12 activators a day? Then what you end up with is this cumulative harm effect. And that cumulative harm effect, as each new dump, even though it's tiny, each new dump that happens, it increases and pushes you closer and closer to the threshold. And eventually...
sorry.
You have a question?
Yeah, I just wanted to, so like another example of that might be like that someone living in like a war zone.
Or it might be living in a war zone, but it might be living in a house where where the environment's pretty chaotic, where there's a lot of yelling and screaming and a lot of parenting based on annoyance. There's no rules necessarily. It's just whatever annoys you today is what's going to get you yelled at. Does that make sense? So, or if you're in a work environment where the policies and procedures don't match what's done and you're held accountable for things that you don't have any control over, that can do it too. Does that make sense too? Okay. So essentially, this is kind of problematic for us. The final one that leads to the presentation of this has to do with low intensity, but with long duration. In other words, no single day is particularly awful, but it is the lack of ever getting relief from it that becomes problematic. So we see this in situations, for example, when people bring a loved one in that's got diminished capacity, and while they are caring for this person day in and day in and day in, they don't get any real relief from that, and it begins to overwhelm their sympathetic nervous system. And what we find quite often is they engage in perfectly legitimate, congruent behavior. They get angry, they get impulsive, they get reactive with the loved one because of the fact that it's overwhelming their ability to tolerate by having these constant, repetitive little dumps of the cocktail in their system.
Robert, what's the difference between that one and the red one, the low intensity with high frequency?
Well, high frequency, did you grow up in a family where a parent had the look? Did you?
I know what you mean by that.
And when you got the look, did it put you on guard?
Always.
So that look created a little dump of cocktail into your system. It aroused your system. And if that kind of thing was happening 15, 20 times a day, every day, it's slowly building up a cumulative harm effect. So, but it's tied to these little patterns of behavior. The low intensity one is, there may not be anything going on at all, but it's the fact that you feel that sense of responsibility over this, and you never get relief from it. Does that make sense?
Yeah, it makes more sense.
Okay. Good question. So what happens when we reach the upper threshold of our ability to tolerate the cocktail in our system? We move into two general arenas. One is what we call reactive adaptions, and the other one is what we call reactive mitigation. The adaption is what we do to kind of deal with it. It's the aggressive portion. It's the withdrawing portion. If somebody's coming at you with a knife, you're either going to fight them or run away. Mitigation's a little different. Mitigation is designed to help us experience less intensity. So, that might, if you look at that, depression fits into a mitigating behavior. What it does is you just turn your system down. And the design of mitigation is to reduce the severity or the seriousness of the experience that you're having. We also find that this is common to a lot of addictive processes and a lot of distraction and dissociation processes. So these two things come online. They are survival strategies that come online when the ability to tolerate the cocktail gets exceeded. Is that an easy way for you to kind of think about it, or do you need me to give you a different example?
So just to confirm, these are not things that are done consciously. These are things that just become kind of habituated.
That's correct. They are just reactive, survival-based behaviors.
Okay.
They're not weighed or evaluated, but are automatic and reactionary. These adaptations are impacting the entirety of the body of a person, and they're often linked to what we would consider to be problem behaviors or psychiatric issues. So let's kind of play with the threat stress response system a little bit and see if it makes sense to you and can support what we've already been talking about. How fast does the body's threat stress response system come online? Does anybody know? I'm going to guess that silence means nobody knows. Depending on the research you're looking at, it usually ranges somewhere between 9 to about 20 milliseconds to bring this system completely online. Now, that's a problem when you consider how long does it take to get your executive functioning system online. Once again, through research, we're looking at a kind of a norm that's broad, somewhere between 85 milliseconds to 150 milliseconds, just to get the system of thinking on. Not to think a thought, just to get it on, just to get into the executive functioning system. So with the threat stress response system being so sensitive, it makes sense that we can get into it so much faster and so many more times than we can get into the executive functioning system. What's that set us up is it actually kind of disposes us to being sympathetically dominant. Does that make sense? Did everybody just do your little head nod so I can, okay. All right. So let's talk a little bit about this. We're going to really kind of look at, the normal kinds of things that people do. How many of you have burnt your hand or something like that at some point? Did you have to think about what to do with your hand? In other words, did you sit down and map out a plan? I should do this, followed by that, or did you just jerk your hand out of the way? Most of you probably just jerked your hand out of the way, which is entirely appropriate response. One of the things that when we start looking at the charge, the excitatory charge of the sympathetic nervous system, what we're really looking at is this threat stress response system is designed to shove our whole body into reactive adaptations, not just a part of the body, but the whole body into reactive adaptations. So what's happening here is that we burned our hand, we experience the pain, we jerk it back, we might even do something to make it feel better. We'll run cold water on it. You might put some kind of salve or something on it to make it feel better. But essentially, you are reacting without a plan, without intentionality, without deliberateness. And it's important to understand that, because anytime people are activated in the sympathetic nervous system, they're behaving entirely appropriately for the system that's on. We may not like the behavior. It may be socially inappropriate. It even may be illegal, but it is entirely congruent, correct behavior. So, how many ways do we adapt or mitigate? Because we are fairly complex, we will adapt perceptually, we will adapt neurobiologically, we will adapt emotionally, we will adapt cognitively, we will adapt physically, we will become even adaptive at a cellular level. And that's been a relatively interesting field to kind of study, is that we're actually beginning to understand that we change at a molecular level. And there's a potential that we build a molecular memory based on the experiences that we have in the sympathetic nervous system. We're going to be more ready to react in the future, and we're even affected genetically. Now, I'm not going to talk about the genetic or cellular stuff today, because I'm just laying out the basics for you. But this stuff, when that system is activated, when the excitatory system is on, and it's on too long, it begins to create adaptations in all of these areas. So really what I'm talking about is, from a physiological arousal point of view, what we're doing is forcing individuals into a state of reactive adaptation and reactive mitigation. Melissa, I think you're going to make me seasick with all this moving around.
Sorry, I will block my camera for a second.
The reactive adaptations and mitigations are impacting the entirety of the body. And one of the things, if you're working with children, becomes important to understand is that children are particularly designed to be environmentally dependent. They do not have the capacity or the ability to be independent of their environment. And so if the environment is provoking reactive adaptations, we will see it usually in children more quickly than in any other situation. Now, what we have done traditionally in the mental health world is we have labeled those completely congruent reactive behaviors as problem behaviors or psychiatric problems. So I'm going to go ahead and talk about the elements of the stress threat response system. And I'm going to talk about just basically two kind of global groups. Now, there's a lot of components that are involved in this, but I want you to kind of understand that these are kind of fundamental. And you'll probably want to develop the skill to kind of talk about these with your clients as you begin to move through more into the implementation of trauma as a physiological response. So first and foremost, let's talk about the anterior cingulate of the cortex. The anterior cingulate of the cortex is the body's, it's the body's radar system, if you will. In other words, its job is to study the environment, and it's looking for risk. And actually, it is more broadly than that, but what it's looking for is what's relevant to you. How about that? Is that easier? So the ACC is looking for what's relevant. Well, if I am relaxed, if I'm in a good health, if I am not being stressed, then what is relevant to me has to do with attachment, connection, pleasure, joy, and those kinds of things. And that's what my ACC will pay attention to. But when my body is being dumped with some of the excitatory cocktail, then the focus of what's relevant to me shifts to survival. Now, if that happens, then what's relevant to me is anything that has the potential to create pain or distress or to, in some way, endanger me or threaten me. And the threat can be physical, psychological, or emotional. It doesn't really matter. So one of the things that's important to understand, as soon as the sympathetic nervous system becomes dominant and it draws all of the attention away from the relational, the connection, the pleasure aspects, and moves it to this survival aspect. And that's hugely important, because a lot of times we're looking at people and we're saying, can't they understand what the impact of this is on the relationships that they have? And the answer is probably no, because the system that is deciding what's relevant and not relevant is not the relational system. It's a survival-based reaction system. So what happens when the ACC gets turned on? The first thing it does is it creates a state memory of what we call the environmental context. In other words, all of what you're experiencing, both physically, sensory, emotionally, there's a gestalt created of that, and it's remembered in your physical body. It is not a recall memory. You can't access it directly most of the time. However, you've all experienced this at least once or twice in your life, where you've walked into some place and there's no clear reason why, but your whole body has come online and it is aroused, it's anxious, it's nervous, and it doesn't feel safe. Have you all had that experience? What has happened is some element of that has activated a state memory. State memory is so incredibly efficient at helping the body be activated. Remember how fast the executive system works. Take me 100 milliseconds just to get into that system. And if I had to then make decisions and make choices and react to it from that point of view, I might be dead. But with a state memory as an activator, what happens is everything in the context is activated in my body in that very short 9 to 15 millisecond range. And so it becomes a much more efficient system for dealing with threat or with a potential of hurt. So that's one of the things that's done when the ACC is activated. It creates a state memory that is not a recall memory, but it is a physiologically based memory. And there is evidence that it is stored not only in the brain, but in the actual tissues and cells of your body. If you read some of the work of Robert Scare, he works in trauma, and he's a doctor that actually started doing pain management a number of years ago. He will talk about an experience that I've had as well, and that is what we call stigmata. If you access this memory, it's not unusual to see the bruises that the person got at the time of the event to emerge on the person during the session. I mean, it's not a real common thing, but it does happen on occasion. And it usually freaks people out the first time it happens because it's kind of a weird thing. But if you've read Bessel van der Kolk's new book on The Body Remembers, or The Body Keeps the Score, basically we're talking about the same thing. We create state memory after state memory after state memory that is tied to danger, and it doesn't take much to access those. The other thing that happens is during this activation of the ACC is it sends up our alarm system. In other words, it activates our sympathetic nervous system completely. It activates the dorsal vagal system completely. It reduces or downregulates non-essential processes, which we all kind of know that already, that it downregulates or suppresses immune function. It shuts your digestion down. It does those kinds of things. It suppresses non-essential systems. And it becomes excitatory for survival-oriented physiology. In other words, heart rate goes up, blood rate changes, or blood flow changes, breath volume changes, even your ability to transmit electrical impulses changes during that kind of an excitatory state. And then what it also begins to do is have a negative impact on working memory, because you're not going to encode memory very well in a survival setting. So what happens to us that's kind of problematic? Having the threat stress response system come on is entirely correct, appropriate physiological response to the perception of danger. However, there's a problem with having it on too often or too long. So I'm going to kind of walk you through that. The first thing that happens is that this system becomes expanded. In other words, every time it's used, we have greater capacity to use it again. So what's happening is we're building or enhancing its ability to function over and over and over again. Additionally, what's happening is that we're reducing the reaction time. So now we can shave time off of what's already incredibly fast. If 9 to 15 milliseconds wasn't fast enough, we're going to speed that up. Another part that's kind of important to understand, remember the ACC's job is to help you distinguish between what's relevant and what's not relevant. But that takes some effort on the ACC. So as the ACC gets activated over and over again, what we see is that it begins to collapse categories. So let me give you a metaphor for collapsed category. So you probably have in your worldview an image of or a category for flowers. And whatever you think about flowers, probably a good portion of it is fairly neutral. And one day you're exposed to this flower that creates a tremendous allergic reaction. You have to go to the hospital, you have to get some shots, you have to have a breathing treatment, and you spend the better part of the day kind of being asthmatic. Now what has happened is you have a category of flowers and you have a category flower. And those two are very different. Now, over a period of time, you may be exposed to several flowers that create that same kind or similar response. How the economy of the brain does this, it will collapse the whole category. And now all flowers are dangerous. It's not the reality. You may only have 4 or 5 or 6 flowers that are dangerous, but because of the economy of the physiology, we're going to collapse that whole category and make all flowers now dangerous. The problem with that is that we now have a distorted perception of what is dangerous. We have a distorted understanding of a whole category. Think of what you've seen in clients before when they desperately want to be connected with somebody, but when a person makes an attempt to connect with them, they react in a very negative way. What's happened is they want something, but they have collapsed the category around relationship to where relationship is dangerous, and they're going to react to that attempted connection as if it's a threat. That is a completely appropriate physiological response to having the system on too much. Another portion that is kind of unfortunate with having the threat stress response system on too long and too often is that it shifts our focus away from being self-reflective. In other words, a lot of that ability of ourselves to sense ourselves, our ability to kind of decenter and think of ourselves as an active agent in the world or to be reflective on our own experience gets hijacked, if you will. And we become externally focused. It's easy to begin to see ourselves as a victim, and it's easy to see ourselves as being a reactionary agent rather than being in charge of or in control of our own life. One of the outcomes of that is, and remember, this is appropriate because we're in a survival system. One of the outcomes of that is we become increasingly self-centered. So let me give you an example of that. You are swimming in a large body of water. You can't see the shores on either side. and you've gotten fatigued, and the only thing keeping you up is a little tiny personal flotation device. And if you don't have it, you're going to drown. And somebody swims up to you and they ask you to give it to them, and they try to take it away from you. You are probably not going to be very charitable. You probably might even drown them. Because when you are in survival mode, the appropriate response is narcissism and self-centeredness. So a lot of times we see folks that have been in this system a long time, but when we're dealing with them, we forget that that's what's natural and normal for this system. And we'll say things, well, can't they see how bad this is for their family? Can't they see how bad this is for them? Can't they see what they're contributing to this? And the answer is no, they cannot. That's not a deficit psychologically or emotionally on their part. It is because the sympathetic nervous system has hijacked that system for long enough that they just don't have that capacity. We also will see a reduction in our ability to experience pleasure. Why? Pleasure seeking, attachment seeking is a behavior when the body is regulated and the ACC is looking for those things. If the sympathetic nervous system has been turned on long enough, then we are not looking for those things. What we're looking for is not pleasure, not so much connection. We are either shutting down or being aggressive, or we're being hostile, or we may engage in high-risk behaviors to even feel like we're living. The other side of this is that what works to help particularly a lot of children regulate would really require that the parental systems or the caregiving systems would be able to regulate themselves, because unless the parental or caregiving system can regulate and be self-reflective, they can't possibly be able to help this child regulate. So that's a pretty quick overview of that. There's a lot involved in it, but I'm not going into the detail of. I'm just giving you an overview. So what happens when the system gets activated? We talked about the sympathetic nervous system and the dorsal vagal system coming on. Each have appropriately associated behaviors. So together I sometimes call this the hot system. But what happens is we move out of our upper brain, our ability to think clearly, our ability to have executive functioning, and we move into the most primitive parts of our brain, which we sometimes call that reptile brain, or if you want to call it lizard brain, you could. What we're frequently doing with people in the mental health world is we're trying to treat them when they're in their lizard brain. We're trying to get executive functioning behavior out of a lizard brain. So I want to put this in perspective for you. And you don't need to make any comment. This is kind of a self-reflective kind of question. How many times have you been in discord or in disagreement or upset with a loved one, and they try to tell you how to do something? Or they give you some direction, or they kind of tell you how things really should be. So I'm going to assume that when that happened, because it's coming from a loved one, you were so thankful for that information. You were so open to hearing it. Or, if you're like most people, you might have gotten a little pissy about it. Teaching, instructing, giving direction when someone's in their lizard brain is counterproductive. And yet, over and over and over again, that's what we try to do in the mental health world. We take people that are in this portion of their brain and we want to teach them stuff. We want to educate them. We want to provide them with information, which is important, but then we ask them to be responsible for that information. And when they aren't, then we have all sorts of language around their problem. They're resistant, they're non-compliant, they're not cooperative, they're in denial. We use all of that kind of language to make us feel better because we've approached it from the wrong system. This is why we want to get people out of that system before we actually apply any kind of therapeutic intervention. We need people to be in their executive functioning system to make intentional decisions and to be deliberate about their actions. You cannot be intentional or deliberate in your lizard brain. So these are the appropriate behaviors for these systems. So how many of you are dealing with clients that have anger, aggressiveness, defensiveness, they're reactive, they're impulsive, they're hostile, they're irrational, and they're self-centered? Most of the time in traditional mental health, we've looked at these things and said, those are behavior problems. And what I want you to understand is those aren't problems at all. That's a sign that when you see these behaviors, it is evidence that the sympathetic nervous system is on. Just like taking a bite of an apple makes the stomach come on, this is the appropriate behavior for having that system on. Now, what about the dorsal system? This is what we sometimes call the freezing system, but it has its own set of things that are appropriate. Dissociation, emotional numbing, distraction, self-soothing, reactive, impulsive, and emotional and psychological distancing, as well as being also self-centered. What we have done traditionally in mental health is we've taken the sympathetic list and we call those problematic behaviors. We take the dorsal list and we call it psychiatric problems, and we want to medicate for those. Here's the crux of this. They are congruent physiological responses to having the sympathetic nervous system on too long and too often. So what we end up with is, if you go back to our apple metaphor, what we're doing a lot of times, rather than keeping people from taking the bite of the apple, we're dealing with the waste product that is generated by the system. And if you think about that, a lot of what when we focus on behavior in treatment, what we're really dealing with is the waste product or the congruent, if you will, reasonable reactions of the body. Now, most people aren't talking about it that way because referrals are generated by behavior, or they are, we get referrals based on the kind of psychiatric problems that we're seeing. If we can help people regulate this system, they will begin to auto-correct. In other words, they will begin to heal because they aren't in this system. And the way we've structured the treatment for folks is, first of all, get them to be regulating, then you provide some psychoeducation, but then you're more intensely give them regulation skills. And what we find is that when we get people to be able to regulate themselves, a lot of times they don't need a whole lot of therapy. They autocorrect, even with really significant histories of horrible experiences in their life. So what happens at the point that we exceed our upper threshold of being able to tolerate the cocktail in our system? See if this makes sense. First and foremost is there is no future. We are no longer focused on the future. Let me give you an easy way to think of this. I'm assuming that most of you at some point in your life have been driving, not really paying that much attention, maybe kind of relaxed, and had in your rearview mirror police lights come on. I'm willing to bet that when those police lights come on in your rearview mirror, you're no longer thinking about your destination. Instead, you're thinking about what just happened or what you just did a few minutes before that happened. Because that is naturally the way that system works. Having the police lights in your rearview mirror is perceived often as a threat. Even if you don't have any evidence that it's a threat, it's perceived as a threat and your body reacts to it. Why is this a problem? When you're dealing with highly dysregulated people, you're going to find that they don't have much of a future focus. So what do we do with them when we get them into treatment? Is we want them to develop a treatment plan with us that's goal-based. And they don't have the capacity to really do that. And then what we end up doing is suggesting things to them, and they just go along with it because we've suggested it. But the other piece is people in their sympathetic nervous system are appropriately not going to have any tolerance to wait for gratification, because that's not the nature of this system. And so one of the things I sometimes hear from people is kind of complaints, well, my client can't delay any gratification at all. It has to be right now. If I have an individual, be they adult or child, and they are in that sympathetic nervous system, asking them to wait for gratification is going to be problematic. Why? Because there isn't any future. It's all about this moment in time. So you take this 6-year-old kid and you put him on a behavior management plan. If the family can keep him regulated so he's not in the sympathetic nervous system, it can work really well. But if they can't, then what's going to happen is having to wait, how to start on Monday and wait Monday, Tuesday, Wednesday, Thursday, Friday, all the way up to Saturday to get whatever the carrot is too much for the system that they're operating in. So we have to kind of think about how we do treatment a little differently, that whatever we do has to be in the moment and has to be the rewarding piece at that time. Another piece that's important to understand is that part of the brain gets hijacked when the sympathetic nervous system comes on. One of those parts is the medial prefrontal cortex. Perhaps the easiest way to explain this system is to say that it creates pictures for you, for your memory, and it timestamps those pictures. And really, serial memory is being able to open up the file, if you will, and look at picture after picture after picture after picture that is organized by time. So when people have the sympathetic nervous system on, either the picture lacks a lot of detail and may be overly focused on one or two things, or the timestamp feature may not be in place, or some combination of both. So what this means when you're actually working with clients is sometimes when they're recalling their experience and they tell it, sometimes they tell it one way, sometimes they tell it another. And what I hear sometimes from therapists is things like this. Well, my client's lying to me. They're trying to manipulate me. They're trying to get one over on me. Because every time they tell it, they change the story a little bit. That is completely within the realm of having the medial prefrontal cortex dysregulated. You're more or less kind of guessing at the sequence of things because your memory doesn't have good time stamping function. Do you think that could be a problem for you? How many of you have clients that have big gaps in memory throughout their life where they don't remember whole time periods very well? Another thing that happens at the point of activation is the brain begins to generate a bunch of worrisome fantasies, memories, or repetitive negative thinking around whatever's going on. So let's go back to our police lights in the rearview mirror. What are some of the worrisome fantasies that get activated with that? I'm going to get a ticket. It's going to be expensive. My insurance rates are going to go up. This is going to be embarrassing. I'm going to be late where I'm going. Don't we generate those kind of fantasies? Yes, we do. But that's not all. For today, and today only, we also going to add to that. And that is, we also activate with that our own internal negative messages, what I call the inner critic. I knew better than this. That was so stupid. I know that this is a dangerous place, and I could get tickets here, and I just blah, blah, blah. So This is naturally occurring, correct, physiologically driven behavior when the threat-stress response system is in excitatory mode. You're also going to see your language ability reduce. You're going to see your logic and reason shift away. Your moral reasoning will lessen. How many of you, when you've been upset with somebody, have said something you would normally never say, but you said it in anger or frustration, and it was hurtful? Your moral reasoning just disappears when you're in that state. You become reactive to perceptions. In other words, it's no longer what's really going on, it's what you think it means. And all the non-essential systems in your body are beginning to be shut down. So what does that look like? The first systems that get shut down are your subdiaphragmatic systems. These are all the things diaphragm to your pelvic floor. That includes your gastrointestinal functions. You get reduced nutrition from the foods you eat. You can have elimination difficulties. You're going to experience a lot of inflammation in the joints and body parts. It can lead to things like painful sexuality. It can, for example, if the psoas muscle is being constricted because of the pressure being applied by the sympathetic nervous system, it can actually pull your hips out of alignment, which leads to greater likelihood of having to have a hip replacement at some point. It's a pretty important stuff to understand that when this system gets on and it's on too long, it compromises not only psychological and emotional health, it compromises health, period. Your relational social engagement system gets shut down. It begins to affect the quality of relationships you have. You begin to see the emergence of narcissism and selfish or self-centered behavior. You see poor understanding of social cues. You see a lot of the inability to form and maintain stable relationships. And of course, your executive functioning gets shut down. So the ventral vagal system, which is the one that's the relational system in your body, when it gets shut down, you're not seeking relationships anymore. You may want to be connected with people, but rather than going for intimacy, you may be substituting sexuality. That's not an uncommon thing to have happen. You also may get into the place where you haven't had a connection for so long that fear of allowing people to connect with you can be provocative of the sympathetic nervous system as well. But I think more important to most of us is this one. We need people to be able to access their executive functioning system. They need to be able to regulate their body. They need to have good communication. They need to be able to regulate their emotions. They need to be able to pause before they react. They need to have a certain amount of empathy. They need to have a certain amount of insight, be able to be self-evaluative, to judge themselves and to be discerning. They need to have a certain moral awareness of whatever value system they operate on. We need them to have a certain amount of intuition and even identity. If you think about it, most of what we practice in therapy requires people to be in this system. Think about cognitive behavior therapy, which is an excellent model, but don't you need people to be able to do this in order to use it? We need people to be in their executive functioning system to benefit from any form of therapy other than sensory work. Let me say that again. People must be in their executive functioning system to benefit from therapy. Where do most of our clients come in to us are not in this system. And what happens is when the hot system is on, when they're in that excitatory system of the sympathetic nervous system, then they engage in appropriate behaviors for that system, and they don't have access to this system. What do we try to do with folks is we try to do therapy with them when they're in this system, when they're not in this system. But therapy requires them to be in that system. So when they can't function because we haven't helped them get into this system and stay in this system, then we have all sorts of wonderful terminology that we use with them. We say they're resistant. We say that they are in denial, that they aren't motivated, that they aren't really ready for change. We may have relatively skillful ways of trying to manipulate them into being ready. But the reality is, unless we can get them into this system and help them stay in this system, we will never get the full benefit of the kind of therapy that we can do with people. Does that make sense to folks? Give the head nod again, just so I know you're with me. Okay. So I already kind of went through this. I'm going to skip through this piece. So once again, these behaviors that bring most people into therapy are exactly the right behavior. They're congruent, they're efficient, and they are very much in line with the sympathetic activation of the excitatory system, the sympathetic nervous system. Us expecting people that are in that state to not engage in these is irrational. When you see people that are engaging in them, it can be illegal, it can be unfortunate, it can be destructive to their relationships, it can be making them miserable. However, it is correct behavior as long as that system is turned on. The answer is not to focus on the behavior. The answer is to focus on getting them out of that system. And trust that if we can get them out of that system, the behavior autocorrects. Think about your own self. You are not generally irritable and harsh with people unless you're in a state of dysregulation. When you're calm and relaxed and feeling in control of yourself, you generally tend to be kind and more compassionate. Our clients are not any different than that. What has happened with them is that they have been sympathetically dominated for so long that that has become a habituated place for them to operate. And attacking the behaviors, we know from all of the data that has been collected in the last 30 years, is primarily going to lead us to poor outcomes. So let's stop going after the behavior and start going after calming down this system. So that's kind of my quick and dirty little review of the physiology of trauma, that trauma is a physiological response to an activated system. And that if we want to do the best trauma work, we have to get that system calmed down. Make sense to people? All right. It also is the underpinnings of why we structure treatment the way we do. So as you begin to play with the treatment structure, you'll see that it's designed to get people out of sympathetic nervous system dominance. Give them a great deal of predictability, give them a lot of control. It's very transparent. You're taking people that are highly dysregulated and helping them begin to experience what it's like to be regulated while they're with you. All right. Any questions, comments, evil and nasty remarks?
I have one.
Is it an evil and nasty remark?
It could be.
Let's go.
So where do personality disorders come into all this?
If you're following the thought process of this, you would think that perhaps personality disorders are a bunch of bullshit.
So then why do I absolutely despise working with people with borderline personality disorders?
Because remember the first intervention is you being able to regulate you. They're difficult to regulate yourself when you're around them. They are behaving appropriately for the system that they're operating in.
I don't like that answer.
I'm sorry. You want it to be about them and not about you.
Yes, very much so.
It's always about us. So, and I'm kind of playing with you a little bit.
No, I know.
Let's just talk about the DSM for just a minute. The DSM is developed by committees. there is very little research. I taught this course for a number of number of years at a university level to graduate counseling students. I can tell you, of all the categories in there, only 17% of them have had any research validity whatsoever. They're just committee decisions. And in fact, they were never meant to be used to diagnose or treat people. Robert Spitzer, who is one of the originators of it, if you want to read a really good book, it's called The Book of Woe, and it tells you the history of the DSM. And once you read it, you'll be so angry at what we've done, because Robert was one of the originators of this, and he was basically perplexed. How do we as professionals communicate with each other? And that's what they put it together for. In the foreword of the third edition of the DSM-3, he wrote, right in the foreword, this text is not meant for the diagnosis or treatment or reimbursement of treatment. And that's exactly how it's been bastardized. It was originally meant just to help us communicate more effectively with each other. Now they handed this great name, Diagnostic and Statistical Manual. It sounds so officious. But what influences what's there? Do you have one handy real quick? Okay. So have some fun. Open it up and read the DSM-5 Diagnosis of Post-Traumatic Stress Disorder, and you will immediately see in the very first criteria A, the influence of non-psychological lobbyists. And it reads something like this. It eliminates any disorder. You can't have any kind of trauma from watching videos or any form of media. Now, whose input was that? It certainly wasn't my input, certainly wasn't the input of many people. If that's true, then why are we prosecuting people for exposing children to pornography? So there's this incongruity in it. If you look at the way criterion A has been limited, you will notice that it also is highly in favor of insurance companies' restricted treatment and pharmacology being able to sustain their businesses. So how do things get changed in it? It isn't based on research. When we took out the homosexuality as a disorder, which I think is a correct call, it was done at the petition of about 700 professionals. When they included the GAF score and the GARF, both in there, they were included because there were just about 1,300 people that wanted to do research on it and asked to have it included. This whole physiological thing for trauma was introduced by Bessel van der Kolk. It's really what we would consider developmental trauma. And there were 33,700 people, professionals in the field, that asked to have developmental trauma in order included in the DSM-5. You know what happened? The moment it was proposed, the insurance companies and the pharmaceutical companies had a fit, because there is no pharmacological protocol for developmental trauma. And there is no limitation on treatment for, as far as the insurance companies were concerned. And they said, well, you're going to make everybody co-occurring disorder. And the group that was pioneering this idea said, no, what we want you to do is remove all the diagnoses that are really misdiagnosed because you're not dealing with this, which would have reduced the book from about its current 900 pages to about 190 pages. Because almost everybody realizes that it doesn't have anything to do with these psychological and emotional things. It's developmental systems that are on. Anyway, that's my quick summary of that. Did that adequately answer your question?
It does, because that kind of goes along with the autism spectrum. I have a ton of insurance companies that completely deny it because it really isn't treated with like pharmaceuticals. It's treated with therapy, and they don't want to pay for that because they'd rather give them a pill and send them on their way, because therapy is excessively more expensive.
Well, and not only that, but there is a certain amount of understanding that we have a pharmacological industrial complex that has a direct benefit of keeping people sick. And so, what could really work to heal people, we find less and less available. So it's just unfortunate.
Well, I'm hopeless now. Thanks.
No, I mean, this is why you have to design what you do to fit with what works rather than follow the corporate line of whatever organization you belong to. So, was I just doing some rebel rousing there? Sorry. Every once in a while I get up on my soapbox.
I don't know that my boss of my federally qualified healthcare agency would be so excited with me being a rebel.
Nobody's ever excited with people being a rebel. In fact, I was joking about this today, actually sitting in church instead of doing some other things that I should have been doing. And someone in my little group sent this picture about change. Who wants change? All hands go up. Who will change themselves? No hands go up. Yeah, that's kind of what we deal with. And you have that picture. You got to send it to everybody.
I will. It says who wants to change.
Yeah.
So who wants change? Everybody's hands go up. Who wants to change? Nobody's hands go up. And I think the reframe really is that people are actually healthy when they're responding in a way that is reactive when they're feeling fear.
Mm-hmm.
And that if they weren't, then we'd be really concerned. We'd be sending them to the hospital. Like, why is this person not reacting? There's a danger. They're not keeping themselves safe. And whether or not we believe that they're in danger or not is not the point. It's just understanding that is all part of the process. And it is a transition in a way of thinking for sure.
That is true. Folks, it's 5:30 my time, 8:30 your time. I want to be respectful of that. And I will get the video up probably, before I go to bed tonight. How about that? I'll get it up. And then I'll send it out to you through the Sycamore email. So if you don't get it or you can't open it, just shoot me an email and let me know. Anything else before we wrap up? I'm going to say no comment means no.
All right.
Good night to all.
Good night.
Thank you. Good night.